Hello, my name is Dr. Melissa Seibert, and I am the creator and host of the Dental Digest podcast. This week, I had the privilege to get to interview Dr. Ricucci, and we're going to be talking about some of the most controversial topics in endodontics. Now, Dr. Ricucci has an upcoming webinar, which you are going to want to attend, and he's going to be delving even deeper into these topics. So be sure to be on social media to be looking for announcements for when that webinar is going to go live. Dr. Ricucci has over 100 publications, he's authored 2 different textbooks, and is renowned as a national and international speaker in endodontics. All right, here's our interview. So, Dr. Ricucci, you have published several publications, including journal articles, books, and book chapters based on histological investigation. Although from your publications, it is evident that your histology is closely related to the clinic, it is certainly unusual for a clinician to be this deeply involved with histological processing. So would you tell us how you define yourself?
Well, Dr. Seibert, I have to start saying that I am mainly a clinician. It means I treat patients almost every single day in my clinical practice. But the problem was that since the beginning, I was asking questions to colleagues with more experience than me, and I never got the right answer about what we are observing, about, for example, the reasons of the failure, the reasons for our success. So I was looking for answers to the clinical problem. And the first one to give me the precise responses and explanation about what we observed was my mentor, the late Professor Langeland, who was the greatest histologist in the world ever lived. And he introduced me to the histological technique. Now, you can ask me, why conventional light microscopy and not, for example, electron microscopy like scanning electron microscopy, transmission electron microscopy, molecular biology? The reason is simple, because conventional microscopy using, for example, the old hematoxylin and eosin can give you histomorphology, the morphology of the tissue that you are treating. So, for example, you can say for sure inflammation, no inflammation. You can say for sure if you have infection, bacteria, yes or not. So this is readily explainable also to colleagues who are not versed with histology. So this is very easy to understand. So this is the link between the clinic and the research, and this is the reason why I decided to establish my own histologic laboratory.
And what prompted you to dedicate an important part of your time to this type of research? You've already touched on this a little bit, but would you give us a little bit more detail?
Basically, I started because, at my time, before being a dentist, I am an MD. I am a doctor in general medicine, because at my time, in order to be a dentist, you should be first a general doctor, and then dentistry was just a specialty of general medicine. So I was keeping always in my mind my knowledge, my background, my medical background, and I can say that there is a lot of medicine, a lot of biology in dentistry that unfortunately some colleagues used to neglect sometimes. So at the moment, more and more I am dedicating more time in my laboratory to processing important specimens coming from the clinic. I would like to tell you that my own laboratory is totally independent from any Italian institution or international institution, and most of all, I would like to stress that my activity is totally independent from the market, because I think that a researcher today is credible when the independence from the market is beyond any discussion.
I completely agree with you. I completely believe in the importance of honest science. So, histology is oftentimes considered the gold standard in dentistry and particularly in endodontics. But in your professional opinion, would you always say that this is true? Can histology answer clinical problems? And what are the difficulties encountered in processing human teeth for light microscopy?
Yeah, this is a good question. I do confirm that histology is the gold standard, but there are some problems in the case of teeth and the oral tissues in general. First of all, fixing the tooth is a difficult task, because you have to consider, for example, that the pulp is completely encased in a totally calcified tissue. So if a dentist is extracting a tooth and you want to look at the reaction in the pulp and you drop the tooth in formalin, you are facing problems, because that pulp will not be fixed. Because the fixative, in that case the formalin, can only enter through the apical foramina. So the first problem is fixation. So you have to grind one part of the enamel. You have to prepare a sectioning plan under a magnification using water spray on a mesiodistal direction until you start to see the pulp horn. This is the moment that you can drop the specimen in formalin, and only at this point the pulp will be fixed. If you don't do this, unfortunately you get artifacts. And let me tell you that most of histology, which is published in old textbooks and also unfortunately in some journal articles, this is, there are limitations in that. The described pathology, in fact, are only histologic artifact. For example, if colleagues today open a textbook describing some reaction to something, and you will read that terms like reticular atrophy, fatty degeneration are used. Now, in the pulp tissue there is no fat, so it is so evident that there was a misunderstanding. What are simply histologic artifacts, they were misinterpreted as pathology. And you understand very well that if you come to a conclusion after this observation, you may be totally wrong. Another problem, which is also very important, is the number of sections cut. So many people may think, okay, you do histology today, you have a tooth, you give it to a technician in a histologic laboratory. Well, the technician doesn't know where to start. So it is it is the clinician who is asking the technician what to do. For example, the first step is proper pulp fixation. The second one is cutting a sufficient number of sections. Random sections are no longer accepted. Because if you consider, for example, the pulp tissue present in the pulp chamber, you start cutting from one side of the pulp chamber, and then you have to continue. We call it serial sectioning procedure. So you complete your sectioning, your microtomy, when you exhaust the pulp chamber space, when you are on the other side. And if you ask me how many sections do you need, considering that one section is 4 to 5 microns, you will need, depending on the size of the chamber, 600 to 1000 sections. And you have to collect on the slides all this section, and then you start staining the slide number 1, then number 10, 20, and you need the screening in order to look where the pathology is. Why I am insisting on this? I give you another example. Today we use, when we speak about diagnosis of the pulp condition, we use the terminology reversible inflammation or reversible pulpitis, and we say irreversible pulpitis. Now, you know that we have clinical parameters, and all the clinicians know what are the clinical parameters, mostly based on the type of pain that is present. And then we have histologic criteria. So it is accepted in the general literature that there is not a good correlation between the clinical diagnosis and the histologic diagnosis. Now, from a histological point of view today, we accept that the inflammation is reversible when there is no necrosis and bacterial colonization in the pulp chamber. But pay attention, because necrosis can be minimal, established only in a pulp horn with a bacterial colonization. Now, if you cut only few sections, few random sections, you can cut in an area where there are no bacteria. So your diagnosis could be reversible inflammation. But after 300 sections, then you find the focus of necrosis with bacteria. So you understand that the old studies, just to mention the fathers of endodontics, Seltzer, Bender, Soltanov, mostly Americans, but also some European, they came to the conclusion that there is no correlation. But one of the reasons of this lack of correlation is the technique of microtomy, which is improper. They were cutting few sections. So today you have to use, this is mandatory, you have to use serial sections. And another important limitation was that they did not use any bacterial staining. So think about this. All the colleagues, we have to think. We are dealing with infection. We are dealing with bacteria in the pulp tissue. So you need to stain for bacteria. So this is extremely important. So in conclusion, you need today serial sections, you need a bacterial staining. This is mandatory. And none of the previous articles published in the 70s and in the 80s include this technology. So I have to say that the old studies are not valid today. So with my colleague and great co-worker José Siqueira from Brazil, who is a great, I would say one of the greatest endodontic macrobiologists in the world today, we came to the conclusion in an in vivo studies that if you use strict clinic criteria and if you use very strict histologic criteria, there is a very good correlation ranging from 85 to 95%. So it means that when we have the patient with a deep caries and you are careful enough, you collect the clinical story, you perform all the clinical tests, thermal, electric test, you collect the pain and percussion, palpation and so on. Every clinician knows what I am talking about. Then you have a very high chances to come to the correct diagnosis as to reversibility or irreversibility of the pulp inflammation. But I would like also to tell you something which is very important, because still there is confusion in the literature. Clinically, we can establish whether bacteria have penetrated or not that pulp tissue. This can be said with a certain precision, but pay attention, we cannot say nothing about the extent of the pulp degeneration. I mean, the micro abscess can be minimal, located only in one pulp horn, or it can involve the whole pulp chamber. This is impossible to say based on clinical symptoms and based on the radiograph, because sometimes you don't see any periapical changes. So, and this is the base for a big mistake in some papers appearing today. Well, actually, this is an editorial published by the European Society of Endodontology, because there is a paper in which it is recommended to perform certain treatment instead of other treatment, just based on the clinical diagnosis. And this is unfortunately wrong. This is misleading. So my point is, the patient comes in the office, you perform all the steps to come to your diagnosis, but don't stress this diagnosis with the patient. You keep it in your mind. My point, my personal point is that then you tell the patient, I need to perform anesthesia, rubber dam isolation, I need to access the lesion, remove the carious tissue, and under proper magnification, explore and observe visually the floor of the cavity, and see the quality of the dentin remaining, the color, if it is soft, if it is hard, and to explore and examine with precision the appearance of the pulp if there is any exposure. So this is very important, because you may be wrong in your diagnosis. So you may say to the patient, well, diagnosis is reversible pulpitis, I'm going to save that pulp. Then you open the cavity and you see a drop of pus coming from a pulp horn. Then you are in trouble, and it is embarrassing with the patient. So for this reason I say, given that we have some limitations, when you have a preoperative diagnostic radiograph and you see that you have a carious lesion very close to the pulp horn, then you don't express yourself. You say, it seems that maybe we can save vitality of the pulp, but I need anesthesia and I need to access the lesion. And then you will be not in trouble. Because when you have an exposure and you can see pus or you can see dark avascular tissue in the pulp, then you know that you have a partial necrosis, and then your diagnosis is very precise. But this concept, I understand that it is very, very difficult to be accepted by clinicians. In cases with deep caries, when diagnosis is irreversible pulpitis, in the past, everybody, including me, every clinician, we were performing root canal treatment, pulpectomy. Today, I have to say that fortunately things are changing, because even cases seeking treatment for spontaneous pain with the diagnosis of irreversible pulpitis, if we use our tools, the tools that we have today, meaning microscope, strict isolation, asepsis, good anesthesia, you access the lesion. If you have a partial necrosis, today you can remove selectively the necrotic tissue and produce a wound in the pulp tissue. In other words, we call it pulpotomy, partial pulpotomy. This is not new. It was in the literature since 1970 by Sveck and many other Scandinavians who were great, but at that time there was not good clinical demonstration about that. Today we have the histologic knowledge about the condition of the pulp, and you have beautiful clinical demonstration that you can obtain a clean wound in a continuous blood-filled tissue. This is important. You have to try to obtain hemostasis. If the quality of the tissue is good, you can cap it. And I think that I contributed to that, because reaccessing these conditions, these cases, and removing the restorative material after a period of 3 to 6 months, and you will find a barrier which is continuous, which is mineralized. It is a barrier protecting the underlying pulp tissue. So what counts today is the location of the front of infection. This is the problem that we dentists face today. We have to try to locate the front of infection, and I'm sorry to say, we cannot leave bacteria in the system. This is very important.
This represents a complete paradigm shift, though, because oftentimes, particularly I myself am a general dentist, and oftentimes we are taught that, of course, if there's irreversible pulpitis, of course you're going to initiate root canal therapy. So with microscopes and all the tools that we have available to us, how do you detect the necrotic tissue so that you only remove that in your pulpotomy?
Yes, we recognize it visually. You know, in the past, for example, we were used to say, well, there is a pulp exposure, let's do pulp capping. But that was totally wrong. I did it. Like many other clinicians, we did this. But exposure means nothing. Exposure means that you have a bleeding tissue. But then the problem is, if you see that the color is important, I do repeat, dark means coagulation necrosis. Yellowish fluid means purulent material, so it means pus. It means acute inflammation and pus and bacteria, obviously. So when you face this condition, okay, high-speed burst under water spray, under microscope, you shave off layers of the pulp tissue together with some portion of the pulp chamber roof. So you access the pulp, it will bleed, okay, you wait. I recommend to use sodium hypochlorite for irrigation and wait. And try to obtain hemostasis, okay, you can use sterile cotton pellet, just the pressure. You wait a couple of minutes, then you remove the cotton pellet, then you re-observe the wound and again examine the quality. So if still you see that the tissue is not continuous, is not blood filled, then you remove a second layer and you repeat the operation. It takes time. This has to be clear. Unfortunately, it takes time. And you can repeat these steps 2, 3, 4 times. What is the limit for that? The limit to me is the root canal orifices. If you are in a molar, you have been removing the whole pulp tissue in the chamber and you are at the orifice, this is the limit. If you find good condition of the pulp at the orifices, you perform a full chamber pulpotomy. But if the tissue is not continuous, if you cannot control the bleeding, then obviously you go for pulpectomy or root canal treatment. So it is a process that you have to go step by step. It's not simple, and there are no other methodologies to understand whether you have inflamed but non-infected tissue in the wound. This is the only point.
And so just to be clear as well, you are referring to doing this procedure on adult teeth, not just pediatric, but adult teeth.
In the past, it is true, pulpotomy procedure were accepted only for immature teeth in a pediatric patient. Okay, when you have an immature tooth with open apices, then the procedure is mandatory because only the vital pulp can form the root. This is absolutely true. But I was now talking also about adult patient with fully formed teeth. Yes. So the condition of the root is not an important factor to determine partial pulpotomy. Let me add something more. In the past, in many papers, there was written, you find the information that when you use, for example, calcium hydroxide as a pulp capping agent, the consequence in the future would be irregular calcifications in the root canal system. So this is totally wrong, and let me tell you why. It is wrong because the mineralization in the root, mineralization or resorption, they are caused by ongoing inflammation. And if you have inflammation, it means that you have infection, you have bacteria somewhere in the system. So if you do a partial pulpotomy procedure or pulp capping, and after 6 months, one year, you take a radiograph and you observe irregular calcification in the root canal, this is the moment that you have to tell the patient, pain or not pain, symptoms or not symptoms, this is the moment to remove the pulp tissue and to perform root canal treatment. Why? Because the pathologic phenomena that you are observing are the effect of residual infection. You have bacteria either in the pulp or in the dentin surrounding the wound. So I am trying to say very clearly that these phenomena are caused by infection and not by the particular material that you are using for capping. So I can show so many, and I usually do during my presentation, many cases with pulp capping or pulpotomy procedure followed up to 30 years and without any changes, any pathologic changes in the pulp tissue or in the canal. So the only problem is, the only threat for the pulp is bacteria. So in the long term, it is very important, and as endodontists, we have to be very strict on that. So if we have a success after a vital pulp therapy, the coronal restoration of that tooth must be very, very precise, meaning bacteria tight, because a threat for the pulp is bacterial leakage through the margin of the restoration. So when we perform such treatment, we have to ask the prosthodontist or the restorative colleague, we have to ask, you have to perform a perfect restoration. So this is so important. And this brings me to another point, that the response of the tissue and also the success rate using one material or the other material, the difference is minimal, because it is true that today we have the bioceramic materials. It is true that they are good. The response of the tissue is very good, but the response of the pulp tissue was good also with the old calcium hydroxide. There is one difference. And this is why today we tend to use the more modern materials. The difference is that calcium hydroxide is washed away by the tissue fluid circulating in the dentin. So after some time, the material can disappear because it is simply washed away. Okay, and this is the difference. Both MTA and the new tricalcium silicate material, they are not washed away. So being tolerated, both of them, so we tend to use more and more the tricalcium silicate materials today.
So also, this is $1 million question, and you have already touched on this, but I just want to be clear. So you're saying that in some scenarios, there is a place for direct pulp capping. Of course, you need to follow it, but you're saying that there is the possibility that direct pulp capping can have a positive outcome in some situations?
We perform direct pulp capping only in cases where the clinical diagnosis was reversible pulpitis. Okay, so but let me also say something more, because we clinicians, we use the expression accidental exposure, mechanical exposure. So I question this definition, because the exposure cannot be accidental. I mean, you start carious excavation using low-speed burrs, okay, slowly, carefully in the superficial layer. Then you realize that at a certain point you are very close to the pulp tissue. This is the moment that if you are a careful clinician, you start using only hand excavation, using sharp excavator. At that point, if removing soft dentin, then you expose a pulp horn, this is no more accidental. I mean, it is not your responsibility. You are not exposing the pulp. You are revealing the condition. So this is why I am questioning the expression and the terminology. So it is not accidental. It is accidental if a young clinician is sloppy enough to expose using a high-speed burr or low-speed burrs. Then it is an accident. But normally it is not an accident. Today, there are many dentists who push for what they call selective excavation. Selective excavation means that today you don't need to remove completely the soft tissue, because the pulp exposure is considered a very bad prognostic factor if the pulp is exposed. But again, this is a misunderstanding of the problem. So the pulp exposure is not an accident. The pulp exposure is something caused by the demineralization of the dentin, caused by bacteria, by infection. So if the pulp is already exposed and you do not remove the soft dentin, you carry the risk to leave bacteria there. So personally, I am totally against the selective excavation concept. Well, maybe we can discuss this a little bit later.
So just though, before we go to that, let me ask the $1 million question. Can we regenerate the dentin pulp complex?
Oh, well, this is, yeah, you're right. It's $1 million question. Yeah, it's, no, the answer is very strict. No, unfortunately, no. We have two types of regeneration. We dentists speak about regeneration in two different aspects. One is the regeneration under pulp capping procedure or after pulpotomy procedure, and the other one is regeneration after you have a totally immature tooth, okay, with necrotic pulp. Let's discuss the first one. What is the kind of tissue formed following successful pulp capping procedure or successful pulpotomy procedure? As I said before, you have a mineralized barrier, and this barrier was improperly called dentin bridge. Well, I can tell you that for sure it is a bridge, but it is not a dentin, particularly if you cut histologic section. This is a irregularly mineralized tissue. And what kind of cells are forming this barrier? Molecular biologists believe that there would be new mesenchymal cells, undifferentiated cells, that would be attracted in the site of the damage. They would be stimulated to become odontoblast-like, and these new cells would form the barrier, the bridge. So it was supposed that the bridge is formed by odontoblast with an odontoblastic process going in a tubule of new dentin. Well, let me tell you that this is a fairy tale, because I have been processing hundreds of these teeth with successful pulp capping, and I have never seen regular tubular dentin. Unfortunately, we define regeneration when we observe new dentin. It must be new tubular dentin. According to the definition of regeneration, regeneration means the replacement of a lost tissue with the same tissue. And the same tissue would be tubular dentin with odontoblast. But nothing like this in histologic section. First of all, the hard tissue is not tubular. So it is an irregularly mineralized with some holes in the middle resembling the Emmental cheese. So this is not a new observation. So the tissue is highly irregular. But there is the risk that this discussion is just an academic discussion, because we are clinicians, and from a clinical point of view, what do you want? What we want is that after capping, after pulpotomy, in time, you have a pulp tissue without inflammatory changes. So this is what we want. Obviously, with no symptoms, the tooth has to be functional, responds normally to all the tests. Yeah, but this is what we want, with a mineralized barrier on top. If you get this is, for me, from a clinical point of view, this is the greatest success, but the pulp tissue has to be non-inflamed. So then, if there are new odontoblasts or there are new fibroblasts and irregular tissue, I don't care clinically. So this is the point. So it's an academic discussion, but it is true that we cannot regenerate the pulp following pulp capping procedure. Now go to the other situation, the situation in which you have, for traumatic reasons, or for example, for the malformation in mandibular second premolar dens evaginatus, causing premature necrosis and open apices. Okay, the idea was that starting from 2001, a group of Japanese, they treated a tooth like this, disinfecting the tooth, causing some bleeding in the canal and covering everything with MTA. And they observed in time the disappearing of the periapical lesion and maturation of the root with some thickening of the dentin wall. Well, clinically this happened. Why not? And they interpreted this clinical observation as regeneration of the dentin pulp complex. Okay? And for many years, we were used to think that doing this, inducing bleeding to attract the undifferentiated cell, would cause differentiation into new odontoblast, which would form new tubular dentin. Well, unfortunately, histology, particularly in human cases, in human teeth, okay, has demonstrated that the tissue is all but dentin. Is a mix. Sometimes you can observe bone tissue, sometimes you observe periodontal ligament, sometimes you observe cementum, and the tissue is just a connective tissue which has nothing of the original pulp tissue. So once again, clinically, we like when you start with an open apex, okay, and then you induce disappearing of the periapical lesion and some thickening of the wall. Again, clinically, we love it. This is what we want. Okay, but please forget that the tissue is the original dentin and the soft tissue is the original pulp. I think that we are a little exaggerating or stretching the concept. I would call it repair in terms of general pathology, not regeneration, but again, clinically we like it.
So your publications deal with topics that there is not unanimous agreement among clinicians and researchers. Let's discuss some of these controversial topics. And we've already touched on some of them, but you recently published a paper on white spot caries lesions. Is there anything new about this subject that you've discovered?
Yes. Again, we contributed to worsen the condition because what we call white spot or early or incipient caries lesion, it was believed in the past that bacterial biofilm is only superficial. Okay, so it was implied that clinicians should advise the patient to regularly floss in the proximal spaces and eventually place fluorides or other chemicals, to induce remineralization. But the idea was that in non-cavitated lesion, there would be no bacteria in the enamel. That was the idea. And recently, some colleagues, they proposed new they call it micro-invasive techniques, consisting on acid etching, of the superficial enamel, followed by infiltration with some resin, fluid resin, and this treatment would block and would isolate the enamel from the superficial bacterial biofilm. Well, but unfortunately, once again, using conventional light microscopy in this white spot lesion, we found that unfortunately the bacteria and the bacterial biofilm, they can traverse the entire thickness of the enamel and form biofilm at the junction between the enamel and the dentin. So these findings, raise some problems, some new problems, a new question. Okay, if you know now that this is true, that you have bacteria already reaching the superficial end of the dentin, if you seal the enamel, what is the fate of the bacteria that we are living? This is the question. So, will these bacteria survive because they get nutrients from the dentinal fluids, from many sources, or they will die? We don't know at the moment, but this is a new fact that will need to be taken into consideration. Unfortunately, when you have the white spot lesion, you have spaces created among the crystals of the enamel, so the enamel is totally permeable to bacteria, and this will need further research. But for sure, in the white spot, bacteria are already penetrating the enamel up to dentin. And even worse, we were able to describe incipient reaction in the pulp tissue. Because as soon as the dentin is reached by bacteria, then you start immediately to observe histological reaction. Minimal, but they are already there.
This is also a question that my boss, Dr. Greg Zielinski, had. When you finish your cases, do you strive to see a sealer puff at the end?
Yeah, this is the most controversial topic in the endodontic world. You are right. It is. You are referring to the topic of the apical limit of root canal instrumentation and obturation. Yeah, obviously, the father of this controversy was Professor Schilder from Boston. I met him personally. I was a young dentist at that time, and he was a great clinician. In the Schilder technique was, the most popular in the world. But once again, producing a sealer puff in the periapical tissue is regarded in general by clinicians as an example of tightness of the root canal filling. But is it really so? Well, I would like to say that having the full control of the fluid part of the obturation is really difficult. You may have a ciliar puff even using the called lateral compaction of gutta percha, because you can control the gutta percha but not the cilia. So it is not a big tragedy, but usually the overfilling you are talking about is the effect of the working length determination. I mean, Schilder was the first one to insist that the ideal limit would be of the procedure would be the radiographic apex, the top of the root. But Schilder admitted that if you do so, you are already in the periodontal ligament. Other schools in time, in many textbooks, they wanted to identify and to locate other points. For example, in some textbooks there is written that the ideal limit would be the cementum-dentin junction. Well, this is for sure a mistake, I can tell you, because the cementum-dentin junction is a histological point. You cannot see clinical, no way. And in addition, let me tell you that if you cut section, longitudinal section through the foramen, you will see that the cementum-dentin junction on one side of the canal is located at a certain level, and on the opposite side it is located sometimes at a distance of 3-4 millimeters. So it's impossible to locate the cementum-dentin junction. So I really invite to forget this terminology. The other terminology that we should consider is the minor diameter or apical constriction. This is a different story. Regardless of the combination of tissue, I mean, you may have dentin and dentin, cementum-dentin junction and cementum. I don't care about that. The important part is that it has to be the area which is for sure is shorter than the radiographic apex, the area with the minor diameter. There, I belong to the biological school, so our goal is to produce a clean wound at the apical constriction and to just adapt the obturation material, because this is a basic principle of wound healing. Keep the wound as small as possible. Okay, so this is basically the difference between the biological school and the Schilder and post-Schilder school. They want to establish the apical limit beyond the constriction in the foramen, but the result is that you always destroy the apical constriction, and the obvious consequence is that you may push some material beyond the limit of the root canal, obviously. I'm not saying that you kill the patient by doing so, but certainly you are creating a larger wound. And I admit that today colleagues are too much exposed to the concept of, of the Schilder school and post-Schilder school, because they want to do, for example, the patency. Patency file is another concept that many clinicians are embracing today. Patency originally means passing a small K file, number 810 K file, beyond the limit of your preparation with the intention to avoid debris accumulation in the apical part. So if you ask me if I accept patency, I would say no, not even in necrotic cases, and the reason is simple. If you are careful enough to create a clean wound at the constriction, bringing all your instrument to that point. Let's imagine we are talking about vital pulp, okay? You are creating a small wound there, and then you pass beyond the wound with a small instrument. You are destroying the tissue that you want to keep, so it doesn't make sense in vital cases. Let's consider the other condition in which you have total necrosis. It is true that in cases with long-standing necrosis, you may have bacteria and infection in the apical third, even in the foramen. So if you do your patency with the intention to break, with the intention to disrupt the bacteria biofilm eventually present, okay, you may even succeed in the main foramen. But how about the other foramina? So the idea that we have one canal and one foramen is wrong. If you observe with some magnification, whatever apex, you will find 2, 3, 4, 5 foramina. So, okay, you are disrupting the biofilm in one foramen, and how about the other? So, I usually do not recommend doing any patency in any case, because there is another reason. Because many times the patient is totally asymptomatic, is coming with an asymptomatic periapical radiolucency. The pulp is necrotic. Okay, you instrument, you do your patency, and you are carrying bacteria beyond the limit of the root canal, and the day after the patient is back with a beautiful flare-up. This is something that happens sometimes, and it is very embarrassing for the clinician sometimes. So I would say I don't see biologically the reason for doing the patency.
Wow. So what about lateral canals? Is it possible to disinfect lateral canals? And is it possible to seal lateral canals?
Yeah, you said correctly. It is possible to fill the lateral canal. But before that, is it possible to clean the lateral canal? So this is the question. And once again, I think that the clinician should make a very clear distinction between cases with vital pulp and cases with necrotic pulp. Because in all cases with vital pulp, removing the vital tissue from the lateral canals is impossible, and this is demonstrated by histology. If you squeeze, this is the term, squeeze, if you push, particularly using, for example, Thermafil, and or the vertical compaction, and you push, you can push some materials into the lateral canals, but does this mean that the canal is filled? No. Once again, histologic sections say that you are pushing some material which is always in section intermixed with tissue which is necrotized or still vital, but the spaces are not filled, this is sure. So in cases with vital pulp, pre-operatively, trying to push materials into lateral canals is meaningless, because you have a vital tissue. The vitality of this tissue in the lateral canal is originating from the periodontal ligament. You have vessels coming in, so forget that you have lateral canals. You treat the main canal, and that's all. Now let's go to necrotic cases. In the majority of cases, you may have a lateral lesion, but this does not mean that the tissue in the lateral canal is necrotic. Most of the time, and this is observed in histology, the tissue in lateral canals is only inflamed, but it is not infected. And the toxins from the main canal, the bacterial toxins, are only diffused through the tissue in the lateral canals to generate a lateral lesion. So once again, you don't need to clean it because the infection is in the main canal. But in time, I do admit, and we observe that in time, cases that are not treated for years, the bacteria and the bacterial biofilm, they can colonize all the spaces, including small ramifications, large lateral canals, and you may have bacterial biofilms in the lateral canal. Now the problem is, these cases, these canals cannot be instrumented, with very few exceptions when the lateral canal is large, and then under microscope you can scout, this is the term, you can scout one or two of these canals. It doesn't mean that you solve the problem. So you have to hope that you are able to make your irrigation circulate into lateral canals. So today we use sonic agitation, ultrasonic agitation of sodium hypochlorite. Some use laser, but still the question is, can we control the infection? Can we destroy the bacteria in this tiny ramification? The answer is unfortunately not. So if when you obturate the canal, you are squeezing, you are revealing the lateral canals, and you know this is regarded as a sign of excellence, technical excellence in endodontics. Every clinician is so proud when in the post-op radiograph you see 1, 2, 3 ramifications filled by filled. I would use the word injected, not filled. Okay, Many of these lesions heal, many don't. Okay, but what is the reason? The reason is that if there were bacteria in the ramification, although you can squeeze material into this ramification, you are not killing bacteria. So if bacteria were there, they keep surviving in the lateral canal, maintaining the lesion. Okay? If there were no bacteria, the cases will heal. So once again, I would stick to the reality, and the reality is the importance today is the front of infection, the localization of the front of infection. There will be cases where infection has been reaching the apical third, okay, and not the ramification, and these cases have a good prognosis. There will be cases in which the biofilm has colonized the foramen, ramifications, lateral canals, and even worse, sometimes they can colonize the external root surface. So I am introducing the concept of extraradicular infection, because obviously if you have a biofilm formed on the apical surface, this is beyond the reach of any instrumentation technique. So we are facing failures. And I am not talking about something really uncommon. This occurrence is observed in 6% of the cases with radiolucency. So it is not really uncommon. So most of the time, in some occasion, you have to think that you are instrumenting, you do your medication, you have a sinus tract, and after 1 week the sinus tract is still there. Then you instrument again, you place again calcium hydroxide, and you wait, and after another week the sinus tract is still there, open, draining. So this, you have to seriously think that there could be an extraradicular biofilm, sometimes calcified. There could be calculus, which is not the periodontal calculus. This is an endodontic calculus.
In the presence of medium and deep carious lesions, several authors recommend partial or selective excavation of the carious tissues. You have recently published a research paper on this hot topic. Can you tell us more?
Yes, we are back now to the concept of selective or non-selective excavation. Yes. The idea, it started, I can mention Dr. Masler in 1967. He was the first to introduce the concept that the superficial bacteria in a carious lesion, the superficial dentin would be infected, severely infected, but the deeper dentin would be demineralized, so affected, but non-infected. This was stated by Dr. Masler almost 50 years ago. And but this was demonstrated to be false, to be not true by Professor Langel, my mentor. But the idea never disappeared, and again was proposed again by many clinicians. And today, I tell you, today it's, for me, from a biological point of view, it is a disaster, because the group of colleagues pushing for selective excavation, they are so aggressive, and they come to the point, okay, that the complete or non-selective excavation, this is their statement, it has to be considered over-treatment. This is unbelievable to me. Over-treatment if you try to remove bacteria. But the very sad part is that more and more even endodontists are accepting the idea. So to me is the end of the world. We endodontists are accepting bacteria over the pulp. I would say today that there is not a single endodontist, a single clinician who does not believe that the pulpal problems are generated by infection. So this is very unfortunate, because there is a recent editorial published by the European Society of Endodontology accepting the concept of selective excavation. But this is another story. Now, let me tell you, what are the problems to be discussed? The problems to be discussed are, if you are pushing for leaving some infected dentin over the pulp, okay, You should demonstrate, it's your responsibility to demonstrate, number one, that the bacteria eventually sealed in the deepest part, they become harmless or they die. This is what I would need as a clinician. Okay, you want me to follow the selective excavation? Give me the demonstration, give me the scientific evidence that these bacteria eventually left, they are going to die, number one. Number two, you have to demonstrate that the underlying pulp is non-inflamed. So these are the two scientific demonstrations. And this is in the total absence of symptoms. So if you adopt the absence of pain as the sign of excellence, you are demonstrating nothing because the pathology takes place in the absence of pain. So Masler never demonstrated that. But now comes my last publication with my group. This is a very, really international group. It was not easy to provide cases in humans, third molars, to be extracted for preventive reason. All these molars should have only a class 1 medium deep carious lesion, only occlusal lesion. So what did we do? We, with the permission of the patient, we opened the cavity, we produced selective excavation, taking a very precise documentation, photos of this condition. Then we sealed in the best clinical way the cavity, and after an observation period, we checked symptoms, response to the vitality test, and then the teeth were extracted and processed for histology and histobacteriology. Now, what was the conclusion? We observed that in all cases the dentin, the soft dentin left under the occlusal restoration was heavily infected. The bacteria stained perfectly. Okay, not only this, but the pulps were inflamed. Okay, not in a severe way, but inflammation was there. So it means that bacteria are metabolically active. So I think that we demonstrated fully that leaving soft dentin, you have to know that you are leaving bacteria which will continue to live, and in time it may take years. In time they will produce the pulpal breakdown. So the way to measure this problem until now was only some longitudinal study, observational study. They did, for example, I don't know, starting from 100 teeth. You do partial or selective excavation and you follow up and check vitality for 2 years, 3 years, in the short, middle term. And some publication come to the conclusion that after 3 years, using selective excavation, you have 90% of the pulps remain vital. And they say, well, it is a very high number, so the procedure works. Come on, this is my objection. 3 years means nothing. If you leave the caries untreated, after 3 years, the caries will be there without any symptoms. So you have to look for some different evidence, which is only histopathology and macrobiology. And unfortunately, when these investigations are performed, then the demonstration is that you are leaving bacteria there. So I would say today to every clinician, try to remove completely this soft tissue until you find clinically sound dentin. Don't be afraid of exposing the pulp. If the pulp is exposed, it is not you who are exposing the pulp, it is not your responsibility, but it is the pathology, it is the caries that was exposing the pulp. You are just revealing the condition. And if you expose the pulp, you have vital pulp therapy procedure to do at that point.
Well, thank you so much. This has been so interesting, and we have covered so many hot topics, so many paradigm shifts. Is there anything that you wanted to leave us with?
You know, my point of view is that dentists in general, the dental professional profession is neglecting in a way the biological principle. But I think that there is a lot of biology, a lot of medicine in dentistry, and we should probably make an effort to follow some sound biological principles. So, for example, particularly for general dentists, I would push everyone to make a correct diagnosis, to spend some more time. You have a carious lesion, please stay there, take a radiograph, try to perform a complete examination of the pulp, try to understand what is the status before drilling the cavity. So spending more time, and then using, for example, strict asepsis. This is so important. Today there are still dentists who do not use rubber dam isolation. This is very sad. So I would push everybody. It is so comfortable to use the rubber dam. It is so easy. Start using. You will have only advantages. And then again, think in terms of bacteria. Whatever goes in the cavity, whatever goes in the mouth has to be sterile. So asepsis is so important. We deal with infection every day. Whatever happens in the pulp tissue, in the periapical tissue, is caused by bacteria. So we have to understand the importance of this. And then, finally, let me come to the conclusion that today no one should be allowed to work without magnification. When I say this, I don't mean necessarily microscope. If you have a microscope, it is even better. But at least a 4 times magnification, a loop is enough. But you need magnification. So, and I really recommend colleagues more and more to use a proper magnification. And if you start using a loop, then sooner or later you will realize that you need a higher magnification and you come to the microscope. This is one of the best tools that we have today in dentistry in all the dental specialties. So this is my last comment.
Well, thank you, Dr. Ricucci. Thank you so much for joining us.
Thank you. Thank you for having me as a guest. Thank you.
Awesome.